Welcome to my little presentation on BPPV diagnostics and therapy using two-axis turntables. A few years ago, we compared the referral diagnosis here in blue with the final diagnosis in patients that came to our center. Clearly, BPPV was the most common referral diagnosis, but after they went through our assessments, this diagnosis got even more common. If we looked at patients 65 and older, we got even more striking results. BPPV as a referral diagnosis, here again in blue, was around 20% of patients. And when the patients left our center, the BPPV diagnosis almost reached 40%. This means that a correct assessment is very important to find out the correct diagnosis, especially in BPPV. Now, the prevalence of BPPV in elderly and especially in frail patients is probably even more common. And this is because the provocation maneuvers in frail patients are not or cannot be correctly performed at the bedside. BPPV in frail patients is therefore probably more common than previously assumed. And this also applies to the liberation maneuver. It is very difficult to do a correct liberation maneuver in patients that are frail. For instance, the Epley maneuver requires quite some mobility of the back and the neck, as you can see here. If you want to go in a head hanging position, this might be especially difficult in patients that are frail. The same applies to the Simon maneuver, which is not possible if you cannot turn your head appropriately to the left or to the right. Of course, you can make it easier. For instance, here with the Epley maneuver, you can put a pillow under one shoulder, which helps to turn the head more to the side. But still, with these tricks, it still remains difficult to do a correct Hallpike and after that Epley maneuver. So the canalith provocation and liberation maneuvers in frail patients can often not be performed at the bedside in a proper way due to stiffness, pain, angst, and other reasons. And as you are aware, many times the maneuvers have to be repeated in order to make the diagnosis, and this puts even more strain on the frail patients. One difficulty is when you tell them to do the self-repositioning maneuver, for instance, the Epley maneuver, that there is a danger that they fall from the bed. Therefore, we sometimes recommend the so-called Foster maneuver, which can be done on the floor. It's also called the half somersault maneuver. It's certainly less dangerous than the Epley maneuver on the bed, but still you need some mobility of your back and your neck to perform the Foster maneuver correctly. So already John Epley had the idea to do the provocation and liberation maneuvers on a turntable, which puts much less strain on the neck and the back of patients. So we agree that the canalith provocation and liberation maneuvers in frail patients are best performed on a three-dimensional turntable. And we showed this a few years ago in a case of a 96-year-old patient that was afflicted with BPPV, and we diagnosed and treated her on a motorized three-dimensional turntable, and I want to show you the video. First, in fast motion, what we did. This is the Epley maneuver. And now we show you the cartoon of the position of the chair together with the binocular registration of the eyes. And here you can see this typical upbeat nystagmus in the torsional vertical direction. And since the patient is in a head-hanging position, this is a geotropic nystagmus. Now we do the Epley maneuver, fast forward. And after the maneuver, we perform the Hallpike maneuvers, the so-called control Hallpike maneuver, which shows us that we had treated the patient successfully on this motorized turntable. So over the years, we had a lot of experience with using this turntable, which can be rotated about 3 axes. And since 2013, we did diagnostics. We also found that right-sided posterior canalithiasis is a little bit more common than left-sided canalithiasis or bilateral canalithiasis. We also diagnosed lateral canalithiasis and anterior canalithiasis. Some patients didn't receive the diagnosis of a BPPV after they were on the turntable for diagnostic purposes. This is another example of a measurement on a turntable. And here, interestingly, is to show you that sometimes you have to perform the Hallpike maneuver twice. And that's what we always do. Also at the bedside, we repeat every maneuver on each side twice. This was the first Hallpike maneuver, and clearly there was no typical nystagmus, only you had the nystagmus during the movement, which is of course physiological. Now, when we repeated the Hallpike maneuver in the same patients on the same side, 5 minutes later, this is what we saw with a latency of a few seconds. You see now a relatively violent geotropic vertical torsional positional nystagmus. So this is just to show you that sometimes it's a very good idea to repeat the provocation maneuvers at least twice, especially if the history of the patients suggests a BPPV. Another example that we could record on the motorized turntable is a posterior canalithiasis in a patient, and he had a very, very long latency, as you can see here. And this shows you that you really should wait long enough, sometimes almost a minute. So this was at 50 seconds, a relatively strong positional nystagmus appeared. Sometimes, of course, we also saw lateral canalithiasis or cupulolithiasis. This is a case of a apogeotropic lateral canal or cupulolithiasis. Clearly, in this case, the nystagmus beats apogeotropic in the horizontal direction. And when we switch to the other side, so-called supine roll maneuver, the nystagmus changes direction after a while, as you can see here. The challenge for the clinician, and this is especially difficult if you don't have video recording, is to determine which side has less nystagmus. And for this, you have to wait long enough and also repeat the provocation maneuvers, in this case, the supine roll maneuver. We also did treatments on the motorized turntable. We performed Epley maneuvers on the right side or the left side. In some cases, we went for somersaulting in the backward direction. So after the Hallpike position, we just continued the rotation in the plane of the affected canal very slowly until the patient reached the upright position again. In some cases, we did somersault forward. This was especially the case in patients with anterior BPPV and for patients with horizontal BPPV. We did either log rolling, or we also started the Guffoni maneuver. So this is how we do the Hallpike and the Epley maneuver. And we sometimes, and this was possible with a motor, did some shaking in the head hanging position. So this is a case of a patient before the Epley maneuver. So now it's being moved in the 30-degree head hanging position. I think it was on the right side. And again, with some latency, a nystagmus appears. And this is the Hallpike after the Epley maneuver, where we clearly see that the nystagmus does not appear anymore. So for the posterior canalithiasis, we did mainly the Epley maneuver and a little more rarely the somersault backward maneuver. Now, motorized turntables are very rare and they are expensive, and therefore we were thinking about helping to develop a turntable that would be have the same possibilities of liberation or provocation of BPPV, but it should be manually driven without a motor. We figured that 3 axes are not necessary, 2 axes are enough. It should be possible to operate the machine by a single user. The turntable should be mobile and transportable. It should be relatively low in cost. It should be optimized for the patient's comfort, and it should allow either low-tech recording of eye movements with Frenzel goggles or high-tech with infrared video oculography, just depending on the needs of the clinician. And this is the 2-axis manual turntable that was constructed by a company for us, and it allows, as you can see, to rotate the patients in the yaw axis and on this circular track in the roll axis, or depending on the position of the inner axis in the pitch plane, or in any plane between roll and pitch. So this is what you need for the provocation and liberation maneuvers of BPPV patients. And the trick is that the center of mass of the patient is in the center of this track. And if you can manipulate, move the patient in such a way that the center of mass will be in the center of the track, you don't need a lot of force to move the patients in this direction. Importantly, we need always 360 degrees possibility to rotate around, because sometimes we want to liberate a semicircular canal by doing the whole 360-degree rotation. The idea was that we would go with this turntable to resident homes, nursing homes, and apply these to patients that complained of vertigo. And this is actually what we did. We went to 10 different nursing homes, and this was our schwindelbus. And with the schwindelbus, we transported the turntable to the nursing homes and applied it to the patients, as you can see in this video here. So the patient first is being seated in the turntable, and then various straps are being applied. We put the patients in the different provocation maneuver positions, and if we see that they have a vertigo together with a positional nystagmus, we apply the appropriate liberation maneuvers. Now, what we saw is a point prevalence around 10%. So here you see the number of patients that had BPPV in parentheses. Sorry. Here you see the point prevalence of BPPV for all 10 nursing homes. And in parentheses, you see the number of patients that were investigated on the turntable. These data points show you the prevalence for each different nursing home. And we found a mean of a point prevalence of around 10%. So that means that at one point during the year, the prevalence of BPPV is around 10%. And if you assume that the duration of BPPV is not the whole year, but a restricted amount of time, then you can compute the yearly prevalence, which will go probably higher than 30 degrees among these patients. But of course, we didn't test that. We only tested it at one point in time. So how do we perform the Hallpike maneuver? This is the Hallpike maneuver on the right side. We usually go to a 30-degree head hanging position. And here you see the Hallpike maneuver on the left side. We always observe an enlarged video of the eye on a tablet, which is mounted to the inner axis of the turntable. Now, here is the provocation maneuver for horizontal canalithiasis or cupulolithiasis for the right side. And here for the left side, again, we are closely observing the tablet for eye movements that would indicate that the horizontal canal is affected by canala or cupulolithiasis. This is the therapy, fast motion, Epley maneuver. In this case, for the left side, And we usually do that in 45-degree step and wait long enough at each position. And now the patient is being put upward. Always we do a Hallpike maneuver for control, as you can see here now. We sometimes also do the Sömer maneuver, which is also easily being done. This is the Sömer plus maneuver, which has been advocated by Michael Strupp in Munich. That means you have to go 30 degrees below the horizontal plane to make sure that the canaliths really leave the posterior semicircular canal. And again, we do a Hallpike maneuver for control, as you can see here. Okay, let me sum up. BPPV in frail patients is probably more common than previously assumed because the maneuvers cannot be performed correctly at the bedside. And this is because the frail patients are stiff, they have pain, they have angst, and therefore the canalith provocation and liberation maneuvers in frail patients are better performed on 2-axis turntables, which can be manual and relatively low cost. Thank you for your attention and have a good meeting.